It's a real pleasure and honor to be here with my colleagues and all of you. I don't think I've ever been called a character more times in an introductory comment. So, I think it's worthwhile to recognize a couple things. One is we are still in the midst of this. We are several weeks into a novel viral outbreak, so we clearly are not done. And I think one of the problems we're going to face is that the press and many people, policy holders, have said, okay, we're finished. This is over. It was hyped. And I think any of us who've been involved in this know that that's simply not true. It is also worth pausing for a moment to recognize that things have gone pretty well, largely due to the great planning that's going on across the federal, state, and local governments. But a Harvard survey last week showed that 80% of the public is satisfied with the government's response so far, and 88% said they were satisfied with the information receiving from the government. And that's fairly remarkable. The federal, state, and local governments have come together as an entity, as an overall enterprise in this response, and that's gratifying, and I think the leadership at HHS and Dr. Besser at CDC deserves tremendous credit for that, and all our thanks. Given that we're into this a few weeks, I think there's already some things we're starting to see that we need to start thinking about hard for the fall, as well as how we continue our response as it is today. First of all, around planning assumptions. Some of our planning assumptions simply didn't pan out. We assumed that this was going to start overseas. We assumed that would give us a month, maybe 2 months, to figure some things out, to figure out what is the transmissibility of this virus, to figure out what was the mortality of this virus. With that knowledge, we could then exercise our plans in the United States, and as you know, that severity puts us on a certain point in our pandemic response plans. That point determines, for example, what kind of social distancing measures we do, as well as what kind of pharmacological and personal protective measures we would take. Well, that didn't happen. It began in the Northern Hemisphere, as we know, in North America, like 1918. So a very interesting aspect of our planning is we forgot the past, and we didn't plan for that contingency. Now, what that also would have meant is that had it started overseas and we had calculated all that, we would have immediately gone into a containment mode. Had there been an outbreak that we identified in the United States, we would have swooped in there, we would have done some isolation and treatment, some quarantine and prophylaxis, and tried to stop the thing. Didn't work. It was here in too many places, geographically dispersed. Their containment simply wasn't a strategy. Again, that wasn't part of our plan. So the important lesson, as we all learn when we plan, we need to figure those contingencies out and come up with scenarios that may happen, rather than a single path as we had done here. Now, the good news about that is I think we adjusted pretty quickly and came up with a mental model of, okay, what severity should we be assuming this is, and let's exercise our plans according to that. Now, we did do that. It meant that initially, of course, we were a little more aggressive with school closings. And as we learned more, we were able to back off. I'm glad that the public is happy with that response, but as we can all see from reading the media right now, the word hype comes up. We had to balance that the very real fact that we didn't quite know the severity, and there's a window of opportunity for taking these measures in case it is severe, against saying, okay, well, we'll wait till we have all the information and then we'll decide what to do. Well, had it been as severe as we feared in Mexico, that would have been too late. And so that balance was constantly being made. And as we know with many of these steps, if you do it and it works, people won't know it worked, and they'll say you hyped it. So that's where we are. But that's just a hazard with the field, and we all know that. So the planning assumptions were very important. We need to revise those. Also, because we weren't able to go to somewhere overseas to determine, it made our own surveillance and investigation systems in this country that much more important, because we had to figure it out on the ground here in the United States. And again, one of the lessons that, and I would say I'm not sure this is universally felt, but we really need to upgrade our capacity for surveillance. We have a number of systems, whether it's the seasonal flu surveillance, sentinel practices. We have a lot of our epidemiological is just boots on the ground type of work. We do have some systems supported with preparedness that are excellent, Connecticut, New York, Indiana, where they are surveying on almost real-time basis what's coming into ERs, who's being admitted. But all those systems are done at a state level, at a local level, and if you look at in the instance of a lot of the epidemiological investigations, we've not standardized the information being collected. We haven't standardized how it is reported. and we don't feed it into a central database. So when we have small numbers of outbreaks geographically spread, we have no way to add that all up and do the analysis to say what's truly going on here. What we do instead is the CDC sends out a team to a given location to investigate and collect the data. But we're not taking these armies of epidemiologists, standardizing their works and feeding them up for analysis. That is something we have got to do. We need electronic systems to do that. Investigation, once you identify something, again, we don't have a standard way of investigating whether it's the pregnant women who get sick or whether it's the hospitalizations. Again, that is done differently in different locations. It is not done rigorously and standardized, so we don't know all we need to know about who are these young people in the hospital right now. What is the course of the pregnant women who are being admitted and hospitalized? And what are their other risk factors? Have they had seasonal influenza vaccines so there might be protection? There's so much we don't know. We need that rigor. We also learned that the granularity of our plans needs to be far greater. Unlike what we expected, that a state would say, okay, CDC, I need the SNS, send it out. They pushed it all out to all the states. And some of those states had no reported cases yet, had no either confirmed or probable cases yet. So here they got a supply. Now what do we do with it? It turns out that in a number of states, absent a governor's declaration of emergency, the standard laws are in place. So laws about pharmacies and who can hold the medicine. What is the chain of custody? Who can dispense the medicine? So some states, with absent a governor's declaration, couldn't actually send their medications out to a rural health center or a local health department to dispense because the pharmacy law says you can't do that. So there's a number of legal issues that came up here. As you would expect, when you actually exercise a plan, you're going to find the holes in it. And we're grateful to find these things, and we need to work on it. Other things about the SNS, for example, a given state might get their N95 masks, and that SNS cache they got could have N95s from 3 different manufacturers, each of which needs to be fit test differently. Their hospitals tend to buy their supplies from one of those manufacturers. So the people who are fit tests in the field may be fit tests for the wrong mask. And we simply don't, in the face of an outbreak, have the ability to fit test all those different people to 3 different masks. So again, important lessons that we should expect to learn. You don't learn that before you're actually in the midst of things. Now, one of the more concerning areas for us has been the issue of vulnerable populations. And I was on a NPR talk show in Minneapolis, and somebody called in, a service worker, to say, I have a fever, I got a cough and a sore throat, and I work in a restaurant. And my boss told me I was fired if I didn't come into work. So I've been working with a fever for the last 3 days. We have many people in the service industry who do not have any benefits. If they take a day off, they lose their job, they lose their apartment, they're homeless. We need to figure out how to care for those people. We also have many people who are migrant workers, and this is the time of year when large populations of migrant workers are migrating. Well, how do they get health care? They don't have benefits. They have no health insurance, and if they don't work, they don't eat. We need to figure out how to care for those people. Furthermore, many of those folks are undocumented individuals in this country. And in this case, many of the migrant workers are from Mexico, a particularly vulnerable population. They won't seek care because they can't leave work, they have no health insurance, and importantly, they're afraid of, if they go to the healthcare system, that they will then potentially be pursued and deported. So a couple of issues here we need to think about. The stigma issue overall, we saw that in SARS with the Asian population, Asian American population. Here we saw it with Hispanic and Mexican population. We need strong political leadership dealing with that issue. But it's more than just statements and communication. We need to figure out how is it we're going to provide care to people who are uninsured and underinsured. The private sector never takes care of them. But even if you just do it for a practical level and not on a humanitarian basis, those kids and my kids and your kids are all going together. And if we don't treat them appropriately, or if we go eat at the restaurant where they're working sick, we're not going to contain an outbreak. So we need to figure out how to care for them. With regard to the undocumented and illegal immigrants, we really need help from the Homeland Security sector here. After Katrina, Secretary Chertoff stated that immigration status would not interfere, should not and would not interfere with the evacuation. And so there was a statement that they would not be pursuing people who evacuated who are undocumented and therefore became known. We have a true problem here. We need Homeland Security and law enforcement in the face of an outbreak to make a statement that if somebody comes in for care or brings their child in, that they will not face legal sanctions in the face of an outbreak. And we did not get to that point, and we still have a lot of fear out there. So the whole vulnerable populations is a big issue to address. I think much of this, and probably the most important thing I hope we can take away from here, is the question is, are we serious as a nation about this or not? We had wonderful leadership by Secretary Levitt about pandemic influenza. He did the 50-state meetings, very effective at engaging the public. And yet we had a single appropriation in 2006 for state and local pandemic influenza preparedness, $600 million. That money was all gone last August. There was not a second appropriation for state and local pandemic influenza preparedness. There was money in the president's budget last time to develop new vaccines, new testing, new pharmaceuticals, all the stuff Americans love, new inventions, but absolutely no investment in the people that would put those shots in people's arms or pills in people's mouths or get them out there. So the question is this just rhetoric in this nation, or are we serious? Are we serious about preparing for the fall, where best case scenario, this thing dies out? Now, we'll let one of our scientists, General Russell, they'll talk about the probability of that, but it would be a huge mistake not to be prepared in the fall for increased surveillance, to see what comes back, because we will both have seasonal flu and likely this H1N1, formerly known as swine flu, returning. Will it come back more virulent or not? We don't know, but we better be prepared. And we need to have our countermeasures ready and restocked. And we face the possibility of giving up to 600 million vaccines in the fall for this H1N1, in addition to seasonal influenza vaccines. We do not have the workforce on the ground to do that. We have not done the logistics to figure out how you vaccinate that many people. We have faced layoffs and job losses over 11,000 people in state and local public health in the last year due to decreasing federal investment and the state economies tanking. We do not have the workforce to meet the need in the fall. We've done well for 2 weeks, but we've taken a one-shift workforce and turned them into a three-shift workforce, and after 2 weeks they're exhausted, much less 18 months of a pandemic. So the question for the federal government and all other governments is, are we really serious, and are we going to resource this or not? And I will end on that happy note.